Hello students, welcome to today's session. So finally we have reached the grand finale, the discussion of the questions which have appeared in NEET PG 2025, and today let's see what came out in pediatrics. So before we begin, let's see what all was there which is highlighted in NEET PG 25. Totally of nearly 15 to 16 questions came from the pediatrics section. The questions which I found were selectively focusing on certain key chapters. 1, genetics. 2 were inborn errors of metabolism and neurology. Now these were the key chapters apart from the 3 pillars I have always spoken to you about: development, immunization and nutrition. So keeping those 3 pillars, we had one question from each, and these were the other chapters that the NEET PG 25 focused on. There was a good mix of what I saw between the problem solving and the recall questions. Clinical problem solving questions were simple questions from simple chapters, which I suppose all of you should be able to do. Moderate level of difficulty, especially when it came to questions which were clinical from the inborn metabolic errors and the child neurology section. But one good thing I found, that if you had a good collaborative knowledge of subjects like biochemistry, we found that knowledge from biochemistry can also help you supplement your answers in pediatrics. So this collaboration is very useful as you prepare for NEET 26. Similar patterns were noted as per previous years, but what I also noticed important was there was a focus on the national guidelines like the NACO guidelines, the infant and young child feeding guidelines. All these guidelines were focused upon and there were key questions asked from those. So with knowing all this, let's begin what the questions were. Coming to the first question. A 3-year-old child is brought to the emergency department with generalized convulsions following a high-grade fever. Now this is the question. Which of the following is the most appropriate first-line medication to manage seizures in this acute febrile episode? Now let's discuss this a little bit. Now what is your diagnosis? Your diagnosis is this is a febrile seizure. Okay. Why is this a febrile seizure? This typically fits into the 6 months to 6-year age group. This has occurred following a high-grade fever. This is a generalized convulsion. Okay. So diagnosis is typical febrile seizures. Now coming to the management. The management of typical febrile seizures is 2-pronged. First is control of the immediate convulsion. Control of the immediate convulsions, the best drug is the fast-acting and short-acting benzodiazepines. So short-acting, fast-acting benzodiazepines are midazolam and lorazepam. Now next benzodiazepine is diazepam. Okay, and the advantage in diazepam also is that it is available in a per rectal suppository. Okay. Now the next prong in the management of febrile seizure is control of the fever, because it's the fever which has resulted in the convulsion. So control of fever as well as control of convulsions should occur simultaneously. So in this, let's look at the options. We have diazepam, we have valproate, we have fosphenytoin and antibiotics like doxycycline or amoxicillin. So going back and recalling, obviously your short-acting benzodiazepine is not on the list, but what is available as a per rectal suppository, especially in a peripheral health center, is diazepam. So your correct answer is diazepam. Valproate, fosphenytoin, doxycycline, amoxicillin will not come as right answers. Now just to discuss further, valproate can be used for prophylaxis only when there is atypical febrile seizures. So atypical febrile seizures following evaluation. This is following evaluation like EEG, investigations. After that, if the parents are very worried and the EEG is abnormal, valproate can be used. There is no role for fosphenytoin unless this goes into a febrile status epilepticus. Doxycycline and amoxicillin are nowhere in this scene at all. So the answer to this first question is diazepam, primarily as a suppository. Next question. A 6-month-old infant presents with frequent infections and failure to thrive. Tests show adenosine deaminase deficiency. Which immunodeficiency disorder is most likely to be responsible for this? Now, any child with immunodeficiency typically presents with frequent infections and failure to thrive. Now, that is kind of the blanket clinical presentation for all children with immunodeficiency. Since it's a 6-month-old infant, the diagnosis is primarily primary immunodeficiency, because secondary immunodeficiencies are essentially following chemotherapy, steroid therapy, cancers, leukemias, etc., HIV, all of it are secondary immunodeficiency. So these are primary immunodeficiency disorders where there are genetic issues with the growing or the naive immune system. Now look at the 4 options. You have severe combined immunodeficiency, you have hypogammaglobulinemia, you have decode syndrome, and you have Wiskott-Aldrich syndrome. Now this point 2, tests show adenosine deaminase deficiency. Adenosine deaminase is an enzyme. This enzyme is present in immature lymphocytes and prevents the development of toxic metabolites and ensures normal functioning of the lymphocytes in the body. Now, in children where this adenosine deaminase is deficient, it means they have mutated adenosine deaminase gene, and this gene causes immature lymphocytes to function inadequately, and because the lymphocytes are the premier cells of the immune system, the child has immunodeficiency. Now, the disease which has adenosine deaminase deficiency is the severe combined immunodeficiency, SCID. So, when you look at adenosine deaminase and mutation in this ADA gene, there is only one disease which comes into mind, that is the severe combined immunodeficiency. So, this is the correct answer, because even without the frequent infections and failure to thrive, ADA deficiency in a 6-month-old infant is essentially severe combined immunodeficiency. Now, let's just look upon the other options. You have option 2, hypogammaglobulinemia. Now, a question on hypogammaglobulinemia, how would it be presenting? It will present very similarly. A 6 to 9-month-old infant presenting with frequent infections and failure to thrive, and the tests will show something different. Here the tests will show reduced immunoglobulin levels. The IgA, IgG, IgM, IgE, IgD, these immunoglobulin levels will be very much lesser. That is why hypogammaglobulinemia. So that will be the question in a case with primary immunodeficiency due to hypogammaglobulinemia. Now, DeGeorge syndrome. Now, DeGeorge syndrome is typically mutation. This is very important. The DeGeorge syndrome, this can be another question, that's why, is a mutation deletion in chromosome 22q11.2. There's a deletion in this gene. Because of the deletion, there is developmental delay. There's a classical DeGeorge's facies. There is thymus absence. The thymus is very atrophic or nearly absent, and these are all very strong immune organs in infants and young children. So that's why children with DeGeorge syndrome have a characteristic facies. They have an absent thymus. They show T cell dysfunction because of the deletion of this 22q11.2 gene. So that is DeGeorge syndrome. So if a question should come like that, you must have characteristic facies, should show a cleft lip, cleft palate sometimes, should show immune dysfunction, should show the absent thymus in the X-ray. These will be questions with DeGeorge syndrome. Now, last option, Wiskott-Aldrich syndrome. The Wiskott-Aldrich syndrome is dependent upon the presence of the WAS gene. This is present on the X chromosome. Now, this gene is responsible for primary immunodeficiency, very similarly presenting with frequent infections, failure to thrive. But what also they have? They also have eczema, and if you do a complete blood count, you will find a falling or a thrombocytopenia. So, Wiskott-Aldrich syndrome has thrombocytopenia, eczema, frequent infections, and failure to thrive. So, you can know all these points, as these can come as 4 separate questions in the next year's papers. You can have the same question twisted towards hypogammaglobulinemia or DeGeorge's or WAS. But currently, when you have adenosine deaminase deficiency, the answer is only severe combined immunodeficiency. Now, going to the next question. Okay. A child demonstrates progressive neurological decline, cherry red spot on fundus. Enzyme analysis shows a deficiency in hexosaminidase A. What is the most likely diagnosis? Now, progressive neurological decline and cherry red spot. What are these? These are the group of neurodegenerative disorders. So in the neurodegenerative disorders, you have GM1 gangliosidosis, GM2, Niemann-Pick, Gaucher's, neuronal ceroid hypophysionosis. You have so many diseases under that neurodegenerative disorders. Neurodegenerative means essentially the child who is developing normally up to a particular amount of time. Sometimes it may be 1.5 years, 1 year, 2 years. After that, progressively the child starts losing the acquired milestones. It can start with losing of gross motor, it can start with losing of fine motor, it can start with losing of even speech, vision, hearing, all these things, and there will be progressive neurological decline. On examination, there is a cherry red spot in fundus. Now, this cherry red spot is a very vague term. Lots of diseases show cherry red spots. In fact, when you look at all the options, which are they? GM1 gangliosidosis, GM2 gangliosidosis, you have Niemann-Pick disease, you have Gaucher's disease. All of these can show cherry red spot at some point of time in the fundus. So, none of these has actually helped us in getting to the diagnosis. What is the next sentence? The enzyme analysis reveals a deficiency in hexosaminidase A. This is where your biochemistry knowledge is needed, because each of these enzymes reflect a different disease. Okay, so let's go to what this question was all about. So hexosaminidase A is typically deficient in GM2 gangliosidosis, which is Tay-Sachs disease. Okay, now Tay-Sachs disease, classical hexosaminidase A. Now, a question which just even says a child who has neurological decline with Tay-Sachs disease shows what? In that you should be able, they'll give you 4 different causes and 3 of them will not have cherry red spot, and then there'll be 1 point saying cherry red spot is there in the fundus. So you should be able to show that yes, Tay-Sachs has cherry red spot. Most neurodegenerative diseases show that cherry red spot. So this question can be twisted in various ways in upcoming exams. Hexosaminidase B deficiency. Now hexosaminidase B deficiency is also seen in GM2 gangliosidosis. So if it is, I'll just write hex B, and there what's the diagnosis? The diagnosis is GM2 only, but the name of the disease is Sandoff's disease. Okay. Now a small discussion on the other options also. What is GM1 gangliosidosis? What is the enzyme? Let's recall. The enzyme is beta galactosidase. So beta galactosidase deficiency. Same question. Second sentence showing enzyme analysis reveals a deficiency in beta galactosidase. The answer will be A, GM1 gangliosidosis. If the answer says the enzyme analysis reveals deficiency in sphingomyelinase, what is the answer? The answer is Niemann-Pick, sphingomyelinase. And Gaucher's disease, you all know Gaucher's disease is glucocerebrosidase. Another important point is the Niemann-Pick and Gaucher's, they are grossly storage kind of conditions. The metabolite gets stored in large quantities and also in extraneuronal organs and the reticuloendothelial organs. So such children can also have a hepatosplenomegaly. So those are all very important aspects when you're looking at Niemann-Pick and Gaucher's. So the answers here which is correct is the GM2 gangliosidosis, which is Tay-Sachs disease. Remember, this question, from this one question, you all should be able to learn 4 simple topics, all covering under neurodegenerative diseases. There are lots of neurodegenerative diseases, but of what we have seen in the previous papers, these are the 4 that they commonly pick around about. So with that, let's move on to the next question. A child with a coarse facial features and development delay is shown to have deficiency of alpha-L iduronidase on enzyme analysis. Which substances are expected to accumulate in this disorder? Now, this is called a double question. The first question you're supposed to diagnose in your mind is the diagnosis of the child. Next, you're supposed to say which substance is to accumulate in this disorder. So, when you have coarse facial features, you have developmental delay. What is your automatic diagnosis? The automatic diagnosis is mucopolysaccharidosis. Classical coarse facial features with developmental delay is mucopolysaccharidosis. Now, mucopolysaccharidosis, there are 7 mucopolysaccaridosis. Type 1, 2, 3, 4, 5, 6, 7 are there. In that, what is most important for you are the type 1 and type 2. Though yes, you can study the type 3, 4, 5, etc. all you can study, but the most important are type 1 and type 2. Now, what is type 1? Type 1 is the Hurler syndrome. Hurler syndrome. This is a large variant, a very significant developmental delay with coarse facial features. And what is the enzyme deficient in that? It is the alpha L iduronidase. This enzyme is deficient. Diagnosis is Hurler syndrome. Now, just for knowledge wise, okay, under this MPS type 1, we have 3 diseases, no? MPS type 1. So, you have type 1H called the Hurler syndrome, which is the maximum affected children. You have the type 1H/S called the Hurler-Shih syndrome, where the symptoms are not so severe. The facial features are coarse, development delay is not so severe. And you have type 1 only S. Now, this is the Shih syndrome, which is a very mild variant. So, Hurler's is a severe variant, Hurler-Shih is the intermediate variant, and the Shih syndrome is the mild variant. All of these are the amount of the enzyme alpha L iduronidase is different in the deficiency. Severe deficiency Hurler's, moderate deficiency Hurler-Shih, and mild deficiency is the Shih syndrome. Okay. Now, going to MPS 2 before we come to the answer. MPS 2 is what is the next most important, that is the Hunter syndrome. And there, same question. Coarse facial features, developmental delay, but what will be the enzyme deficiency? It will be iduronate sulfatase. Iduronate sulfatase will be the enzyme deficient. That is in Hunter syndrome. That is MPS type 2. Okay. Now, our diagnosis here is Hurler. Okay. Now, in Hurler syndrome, what is the, in this one, metabolite which accumulates? The metabolite which accumulates are only 2. They are the dermatan sulfate and the heparan sulfate. Now, chondroitin sulfate, now since it's written there, let's just discuss chondroitin sulfate. What is chondroitin sulfate? Chondroitin sulfate is a normal part of the cartilage process, normal accumulation in various other connective tissues, fibrosis areas. There you have chondroitin sulfate. That is physiologically present in these conditions. Pathological accumulation of chondroitin sulfate is seen in MPS 4A. That's where you see pathological accumulation of chondroitin sulfate. That is a type of Morquio syndrome. That is a type of Morquio syndrome. So, in Morquio syndrome type 4A, you have pathological accumulation of chondroitin sulfate. Now, the other options, dermatan and chondroitin sulfate is wrong. Only dermatan is wrong. And the last heparin and chondroitin is wrong. Because in Hurler, the metabolite which accumulates is dermatan and heparin. Chondroitin will accumulate only in type 4A. So, that is why option A and option D go out of the scene. Option B is also wrong. So, the correct answer is C, dermatan and heparan sulfate. These are the abnormal metabolites which tend to accumulate in the brain, and that's what results in this coarse facial features and developmental delay. Now, in mucopolysaccharidosis, basically, you have Hurler, you have Hunter, you have Sanfilippo, you have Morquio. Now, these are the 4 main common ones which are seen. The last 2, the Mortix-Lamy and the Sly syndrome, are not very common, not commonly asked for at the undergraduate level. But make sure that you know about these 4. The Hurler and Hunter, most important. Next is Morquio and Sanfilippo. Next. So, these all will be presenting very similarly. When you have a lot of bony deformities, you're going to think of Morquio syndrome. That's where your chondroitin sulfate comes into the play. So, this one slide should have taught us a lot about the mucopolysaccharidosis, the types of questions that can come in NEET 26 or above with these kind of presentations in various types of MPS. Okay. So, hoping you all got that. Let's go to the next question. This is a favorite one when it comes to me in complementary feeding, as it focuses on nutrition. A 7-month-old infant has just started complementary feeding using the Katori method. What is the recommended quantity and frequency of feeding during the first day? Now, every sentence here is very, very important. Okay, we have a 7-month-old infant. we have complementary feeding using the Katori method. They have asked the quantity and frequency on the first day. Okay. Now, this has been taken from the IYCF guidelines, or the Infant and Young Child Feeding Guidelines, which is a very important national guidelines on complementary feeding. Okay. So, what does these guidelines say? These guidelines say that complementary feeding should be started between 6 to 8 months of age. This child is in 6 to 8 months of age. So, how do you start? You start using what you call is this Katori method, which is the approximate measurement using a small bowl or Katori. Okay. So, the 6 to 8 month old baby, how should it be fed? You must start with spoonfuls and go up to half Katori per day. Go up to half Katori per feed. Okay. You have to give this 2 to 3 times per day and add 1 to 2 snacks per day based upon the appetite of the child. That is what the guidelines say. That you start with spoonfuls, reach up to half Katori, give this 2 to 3 times a day, and you can add 1 to 2 snacks per day based upon the appetite of the child. So, our current child is 7-month-old. It is going to fit into this guidelines. So, half Katori. So, our Katori value is the same everywhere. It's half Katori everywhere. 2 to 3 times a day plus 1 to 2 snacks, which means you're feeding 3 to 5 times per day. Now, which of these two options come into play? You have option A and B which comes into play. Now comes the importance of how carefully you have read the question. Now, when are you asking? You're asking on the first day. Gradual introduction is the key in this feeding. So, you can give this child 3 to 5 times a day, yes, but on the first day, which actually fulfills the criteria, it is option A, 4 times daily. Ideally, let me tell you, as a point of teaching, we should start complementary feeding at 6 months of age with 1 feed a day. Okay, and then go to 2 and then 3 and then 4 and then 5 and then go further beyond that. But this question, looking at the options you have only 4, 5, 6 and 8. So, on the first day, when you look at the guidelines, you can feed 4 times daily according to these options. Okay. Now, let's just discuss between 9 to 11 months how you will feed. You can feed half Katori 3 to 4 times a day, adding 1 to 2 snacks per day based on the appetite of the child, and you can work up to 3/4 Katori. Okay. So, if this question was focused between 9 to 11 months, how would it be? You can start with half Katori, gradually increase up to 3/4 Katori, 3 to 4 times a day you can give, as well as you can add 1 to 2 snacks based upon the appetite of the child. Now, when the child reaches his first birthday and beyond, till the 2nd year of life, what are you going to do? You can give up to 3/4 to 1 full Katori. 3 to 4 times per day plus 1 to 2 snacks per day. Okay. So, 12 to 23 months, what are you going to do? You had stopped at 3/4 Katori at 11 months. You go from 3/4 to 1 Katori. You can give it 3 to 4 times a day. You can add 1 to 2 snacks per day, as well as the important aspect here is you can start going on to grainier and increasing the texture, making the texture more coarser. So, that is the difference when you are feeding a 1-year-old as compared to feeding a 9 to 11 month old. 9 to 11 month old, the texture is a little bit less coarse, it's more fine. When you're feeding a 6 to 8 month old, it is a complete paste, a pureed foods. Once you reach 9 to 11 months, it's grainy. When we say grainy, we're talking about the rava type of consistency or the suji type of consistency. Once you reach the 12 to 23 months, it can go even more grainier. And by the time the child reaches 1 to 1.5 years, it goes to just mashed food. There's no need to make a very fine paste or make any paste at all. Just hand mashed foods are sufficient. So, I hope you all understood the infant and young child feeding guidelines. Very important to be read. And this question focuses on the 7-month-old child with complementary feeding. Spoonfuls to half Katori, 2 to 3 times a day with 1 to 2 snacks. So, 3 to 5 times a day, but however, it is only on the first day. So, the option that fits best here is 4 times a day and it is half katori. Now, if this was 3/4 katori, 1 katori, etc., the age of the child will, as I have demonstrated, show the increasing age of the child. Okay. Now, with that, this answer is A. Next question. A neonate is born to an HIV positive mother with a viral load of 1200 copies per ml. What is the recommended antiviral prophylaxis for the newborn? Now, HIV is also very important. Here's the other guidelines. You have the NACO guidelines. Very, very important. The NACO, the KSAP, all these guidelines are very, very important guidelines. And everywhere, what do the guidelines state? The guidelines say that 1000 copies per ml. Now, this is what defines a high viral load. Any mother who has a viral load more than 1000 copies per ml is high viral load. So, here you have 1200. So, it is a high viral load. This neonate has been born to a mother who has a high viral load of HIV. High viral load of HIV should be taken very seriously because these mothers will choose to breastfeed, means the exposure to the baby is continuing even in breastfeeding. So, these babies should be managed aggressively, and the aggressive management is with dual or triple drug regimen. So, dual drug regimen is with essentially nevirapine plus zidovudine. We also have called the extended release regimens, where we have nevirapine plus lamivudine regimen, and the triple drug is the nevirapine plus zidovudine plus lamivudine therapies. So, because this child is born to a mom with high viral load, dual or triple drug. Now, look at the 4 options. A says nevirapine for 6 weeks, B says dual drug, C says nevirapine little longer, 12 weeks, and D says zidovudine alone. So, automatically 3 get ruled out. It is a dual or triple drug regimen. So, your answer is B, nevirapine and zidovudine for a period of 6 weeks. After which you are going to go around evaluating the child. You will do repeated tests at 6 weeks, 6 months, 1 year, and then final confirmatory tests at 18 months of age, and then decide how much further you are going to treat this child, what all prophylaxis you will put on the child. So, this question also focuses on a very important section of the NACO guidelines, management of the HIV positive infant and neonate. Very, very important, must be read. So, this answer is B, dual drug regimen, because you have to treat aggressively a baby who is born to a mother with a high viral load. Next question. A 5-year-old child with known chronic kidney disease, that is the most important thing here. Known chronic kidney disease presents with bowing of the legs. Lab results reveal calcium is normal, phosphate is elevated, increased alkaline phosphatase, low vitamin D, that is a 25 hydroxy vitamin D is low. Now, what will you do next? Now, you know this is a child with known chronic kidney disease. You know there's bowing of legs, okay? And you have normal calcium, elevated phosphate, increased alkaline phosphatase. It almost comes under the diagnosis of renal rickets. So, now your questions on the management of renal rickets. Now, in renal rickets, 3 things are very important. You have to manage the vitamin D because the kidney is unable to metabolize the vitamin D into its active metabolite. So, you need to give calcitriol. Very, very important management of renal rickets is calcitriol, because primarily calcium is normal. Calcium absorption also is normal. Another important thing which you have to manage is this elevated phosphate. So, now let's look at the options. A is calcium supplementation, which is not very important right now for me because calcium is normal, okay. B is a phosphate binder, important. C is oral calcium with vitamin D, and D is growth hormone. Automatically growth hormone therapy is ruled out. There is no growth hormone therapy. Calcium supplementation I have ruled out because the calcium is normal. Now, our choices are between B, phosphate binder, and C, oral calcium with vitamin D. Now, the exact point of treatment of renal rickets is to treat the fact that the kidney is unavailable to convert the vitamin D to its active analog. So, the best important aspect is the vitamin D. That is the calcitriol supplementation is very important. The minute the calcitriol is supplemented, the calcium utilization becomes better. This normal calcium will start coming down because it starts getting absorbed and utilized. So whenever we supplement vitamin D, either it's calcirol or calcitriol, we always have to give the calcium along with it, because the minute calcitriol or the active vitamin D analog enters the blood, it will start utilizing the calcium and depositing it on the bone. So the serum calcium level will begin to fall. So oral calcium has to be supplemented with vitamin D. So that becomes the right answer as far as I can see among this. Phosphate binder is important, but it is the next level in the management. Elevated phosphate does retard the formation of the new active bone, and the presence of elevated phosphate should not be neglected. Hence, phosphate binders need to be put. But the most appropriate next intervention for this child is giving calcitriol or activated vitamin D analog along with oral calcium. Only then is the phosphate binder going to come into play. So the correct answer is C, oral calcium with vitamin D. Hopefully they meant the active analog. Coming to the next question. A 1-day-old newborn with significant respiratory distress is admitted to the ICU. Chest X-ray was performed. What is the most probable diagnosis based upon this and this clinical findings? So here you have the X-ray, a very classical, very simple X-ray. So what does the X-ray show? The X-ray shows multiple lobulated kind of swellings. So you have multi-lobulated cystic kind of swellings in the chest. And one thing I want to draw your attention to is that these all things have accumulated into the left chest, that the cardia has been pushed into the right, and there's almost no right lung. Right lung cannot at all be seen. So much of compression is there. So this means there is something occupying the left chest which has pushed the right chest and the heart. So the lung has become hypoplastic and the heart is occupying the place of the hypoplastic lung. Most common condition which results in this is this congenital diaphragmatic hernia. Look at the options. You have congenital pulmonary airway malformation or the CPAM. You have congenital lobar emphysema and you have neonatal pneumonia. Now all of these children will present very similarly. Will present as in the neonatal or in the early infancy with respiratory distress, and X-ray also shows some little different findings. Now what I want you to look at the X-ray very carefully. You find these multilobulated intestinal like shadows, but you can see in this area, let me highlight it. Can you see there's a connection to the abdomen? There's a small connection where this gas shadow seems to connect into the abdomen where there's a large gas shadow. And you can see the nice diaphragm here, and there is no diaphragm on the left side. So this is congenital diaphragmatic hernia, where the contents of the abdomen have herniated through that small area where you can see the connection between the gas shadows. The intestine has herniated through that and occupied its place in the left hemithorax. And that is why the diagnosis is congenital diaphragmatic hernia. Just to make things clear, I put up a few more X-rays. Now you look at this X-rays, okay? Look at the first one. Very similar, multicystic swellings occupying here also, you see? Cystic swellings, occupying the left hemithorax, and you can see the cardia is pushed to the right side. But what do you see here? Look carefully, look at this area. The diaphragm, which is nicely seen here, you see a nice diaphragm here too. You are not seeing any connection like you saw in the previous one between the lung and the abdomen. Hence, this is a case of congenital pulmonary airway malformation or cystadenomatoid malformation of the lung. Similarly, another similar X-ray here. This is also CPAM malformation. You can see the large cystic swellings here. These are all cystic swellings on the right side. Now, swellings on the left side are a lot easier to identify because they tend to push the heart. But swellings on the right side are very difficult to identify. That's why I put up an X-ray for the right side swelling as well. So this is the cystic adenomatoid malformation or the pulmonary airway malformations, where there will be similar cystic swellings looking like the intestine, but you will not see that connection with the abdomen. You will find the abdomen gas shadow, you will find a distinct area, and then you will find the lung shadows, and that area is what has been occupied by the diaphragm. So that is why these are CPAM, and that was congenital diaphragmatic hernia. Now look at this. Now this exercise is very clear. You can see a nice opalescent area in the right upper lobe. Now the heart looks normal. If you see the diaphragms are kind of tented. This is called tenting of diaphragms. Tenting of diaphragms. Diaphragms are like this, and this is the hypolucent or the opalescent shadow of neonatal pneumonia. Okay, this is also very similar presentation. Small infant present respiratory distress in the ICU. However, heart will be in place, and there will be a shadow, a consolidation like shadow in the right side or the left side. That is neonatal pneumonia. Diaphragms are tented means there is some amount of respiratory distress. It causes hyperinflation. That's why they're tenting of diaphragm. Now looking at this, can you see this area? The heart is in the center, but the upper mediastinum is kind of shifted to the right side. Now this area looks hyperlucent. This hyperlucent area meaning it is looking more darker or blacker, like there's more air and less bronchovascular markings as compared to the other side. Now this is where there is this giant cyst or lobe which has got involved. So the entire left upper lobe has got involved and there's a large cystic area there. So this diagnosis is congenital lobar emphysema. Okay, this is lobar emphysema. Here also heart will remain mostly in the center. Apart, maybe the upper mediastinum may be shifted this side. Sometimes the heart may be shifted to the left side if there is this large cystic kind of single swelling occupying one lobe of the lung. That is congenital lobar emphysema. You will not see, you can see in this, you can appreciate so beautifully the diaphragm on this side. You can see the diaphragm like a nice white line, and that kind of line you should have seen. If you had seen in the first one, it would have been a CPAM malformation. That what came in NEET showed a connection in the air. That's why it was congenital diaphragmatic hernia. Coming to the next question. A tall male child with long extremities, lens dislocation and arachnodactyly is evaluated. Which genetic mutation is most likely involved in this case? Now this is a diagnostic case, clinical scenario case. Now you have tall stature. You have tall stature, you have long extremities, which means increased arm span, very tall child, increased arm span, long limbs. Arachnodactyly means spider-like fingers, where you have this metacarpal index, ability to hold the hand, where the hand covers comfortably over the wrist of the other hand. All these are the indices which are done. And in which disease is all this done? Where do you have long extremities, tall child, you have dislocation of the lens and arachnodactyly. Typically diagnosis is Marfan's syndrome. Classical lens dislocation, long extremities, arachnodactyly. So your diagnosis is clear, it is Marfan's. And now coming to the next question. From Marfan's, which is a gene deficient? The gene deficient is the FBN1 or the fibrillin gene. So the correct answer is A, fibrillin 1 gene. So let's discuss the other options. The other options are collagen type 1 gene, you have elastin gene and dystrophin gene. Now, what are the questions which can come from that? Let's revise that also. The collagen type 1 gene is deficient in osteogenesis imperfecta, Ehlers-Danlos. Here is where you have the deficiency of the collagen type 1 gene. Now, osteogenesis imperfecta and Ehlers-Danlos syndromes are all syndromes where there is joint hypermobility, skin hyperlaxity. Now, since that's not written in the clinical case scenario, we are not going to consider those diseases. Okay. Elastin gene, where do you see it? You see it in cutis laxa. If the question showed that there was extreme lax tissue, that the skin is very, very elastic, the child can do acrobatics very easily, all that is cutis laxa. The gene deficient is elastin gene. Collagen type 1 gene, joint hypermobility, tissue fragility, as well as this laxity, All these are Ehlers-Danlos syndrome, and osteogenesis imperfecta has classical, very typical bony deformities. Dystrophin gene, which is a complete out of the scene here, this is for Duchenne's muscular dystrophy. This is the disease which occurs in older children, and this is where the dystrophin gene causes the muscle to get slowly destroyed. So the muscle fibers get destroyed, broken, and get replaced by fibrosis. The child slowly starts losing the motor milestones. Child will start finding difficulty to walk up the stairs, difficulty to play, and then slowly start climbing on himself. That's called the goer sign, where the child climbs on himself, meaning just like an old person, if a child is standing with feet and hands on the ground. To get up, he will support himself on his knees, then slowly on his hips, and then get up to standing. That is goer's sign. Okay, so I hope you all understood these 4 diseases, the 4 clinical scenarios which can come along with their gene deficiency. Okay, so today we have studied in this slide, we studied Marfan's, we studied Ehlers-Danlos and osteogenesis imperfecta and the gene, we studied cutis laxa and the gene, and Duchenne muscular dystrophy and its corresponding gene. So based upon how the clinical scenario is presenting, based upon that you will have the clinical picture and the diagnosis. Okay, so for this question, diagnosis Marfan's, answer is option A, fibrillin gene. Next question. A child suddenly develops respiratory distress after aspirating a peanut. What would you do next? Immediate management, what is the next step? Now remember, this is a sudden choking episode. The peanut has suddenly lodged itself in the laryngopharynx or the upper trachea above or below the vocal cords of the child. So what is the next best step? A, abdominal thrust or Heimlich's maneuver. B, back blows and chest thrusts. C, tracheostomy, or D, bronchodilators. Now this is a foreign body. Okay, there's a foreign body aspiration. So when there's a foreign body aspiration, we do not administer bronchodilators. So that is out of the scene. Okay, so you have 3. You have Heimlich's, you have back blows, chest thrust, and you have tracheostomy. Now, even when the child is small, so essentially in children, it's very difficult to do a Heimlich maneuver, because a Heimlich maneuver involves you putting your hand in front, fisting your hand in front of the patient's abdomen and giving a violent press inside, so that you're causing a violent expulsion of the foreign body. This is very, very difficult to do in smaller children. So in smaller children, what you do, you invert the infant onto the extended leg and apply back blows and chest thrusts. So that is what you will do in a child, so that the child can so that the child can expel the aspirated peanut. There is no question of Heimlich's maneuver in children. Heimlich's maneuver is in older adolescents and adults, or much taller children, where you can actually make that fist and actually pump into the upper abdomen and cause that forceful expulsion. In smaller children, there is no way of doing Heimlich's. Best step is keep the child on the extended knee, back blows and chest thrust from bottom. That will help, and the child is in that incline down. The child will be able to expel that aspirated peanut. So the correct answer is B, back blows and chest thrust. Performing tracheostomy and all is conditions where there's sudden acute narrowing in the upper airway, and with the foreign body, it's very, very difficult and immediate step of management to do a tracheostomy, because we do not know where that foreign body is lodged. This is usually done when you're considering severe croup, where the child gives you some time to settle. You can start oxygen and do. It is nothing to do with aspiration maneuvers. Okay, so tracheostomy also will not be a correct answer here. Okay, none of these. Okay, so coming to next question. The family pedigree here reveals multiple individuals with symptoms like progressive eye movement limitation, retinal pigment changes, and disturbances in cardiac conduction. Based on these findings and the inheritance pattern which is shown here, which is the most probable diagnosis? A, DMD, Duchenne muscular dystrophy. B, Kern-Sayre syndrome. C, Friedreich's ataxia. And D, myotonic dystrophy. Now, let's take this in 2 sections. First, what disease are we dealing with? We have ophthalmoplegia. No, progressive eye movement limitations. Yes. We have retinal pigment changes, like pigment changes in the retina, disturbances in cardiac conduction. Now, I know it's very difficult to actually memorize all syndromes and all findings and everything, but for those who know where these 3 triad comes, where you have ophthalmoplegia, cardiac conduction defects, and retinal pigmentation, automatically your diagnosis is kind of made. The diagnosis is Kearns-Sayre syndrome. Now, what about children who have not studied Kearns-Sayre syndrome? Because it's not a common syndrome to study. There you should be able to rule out the other things. What is Duchenne muscular dystrophy? We just discussed in the previous slide. The child has difficulty in walking, difficulty in motor milestones, essentially starting with difficulty in walking up the stairs, performing squatting and major muscle activities, and then slowly that will progress upwards. Child find difficulty in fine motor movements, and then slowly going on to cardiac issues. Okay, so it's a very slow process which occurs over many years, and child becomes bedridden. That's Duchenne muscular dystrophy. There'll be pseudo hypertrophy of the calves. There'll be Gover's sign of literally climbing on one's body. All this is Duchenne's muscular dystrophy. There is no eye movement or retinal disturbances in DMD. Okay. Friedreich's ataxia. Friedreich's ataxia is a totally different condition. It's a condition where there's rock bottom feet, where there's ataxia, inability to walk in a straight line. There's swaying and swinging truncal ataxia. That is Friedreich's ataxia. That's also a completely different condition. It has nothing to do with eye movement or retinal pigment or even cardiac conduction for that matter. Myotonic dystrophy. Myotonic dystrophy is also a muscle degenerative disorder. But the classical thing is something called myotonia. Myotonia means the tone of the muscle is more. The tone being more means what? It means once the child has performed a contraction of a certain group of muscles, child finds it very difficult to actually relax the muscles. So I have found my patients with myotonic dystrophy, when they want to eat, the child chews and finds it very difficult to actually relax that chew, swallow the food and open the mouth again for the next mouthful. Child holds something, child holds very tight. Even if the child wants to leave, it takes a very long time for the child to actually release the hand and the myotonia to go. This is myotonic muscular dystrophy. Slowly this goes on to weakness, muscle wasting, difficulty in cough reflex, accumulation of secretions in the lung, and that's essentially a downhill course in its own way. There is no eye movement limitation, retinal pigment changes in this. So most probably just by looking at that much, you should be able to know that the diagnosis is Kearns-Sayre syndrome. Now, they have also given an inheritance pattern. Now, this inheritance pattern should help you confirm that it is Kearns-Sayre syndrome. Okay. Now, so coming to the other options. So now, how is the inheritance pattern in Duchenne muscular dystrophy? Duchenne muscular dystrophy is X-linked recessive inheritance. Okay. So Friedreich's ataxia is a autosomal recessive inheritance. And myotonic dystrophy is an autosomal dominant inheritance pattern. So let's come to Kearns-Sayre syndrome last, because these are easy. X-linked recessive means what? The males should be affected. Here you can see itself female affected. Female being affected in Duchenne muscular dystrophy and X-linked recessive is very, very rare. And here you're seeing 1, 2, 3, 4, 5 females affected. So it is not Duchenne muscular dystrophy. This is not X-linked recessive inheritance pattern. Is it autosomal recessive? Now for autosomal recessive, these all should be carriers. Okay. The autosomal recessive means the mother is affected. The mother gives a carrier gene to everybody. The father is apparently normal. So unless this father also was a carrier, it is very, very unlikely to have 2 boys who are affected here. Okay, in autosomal recessive, the father should have been a carrier for this to happen. And even if the father was a carrier, we are having this first child who is normal. And what does the normal have? Worst this person should have been is a carrier. Okay. Now, this carrier seems to have a suffering twin. So that is why this cannot be an autosomal recessive inheritance, because carrier cannot have an actual child who is suffering. It is a negative trait. So this person cannot have an actual suffering child if he is only having one abnormal gene, unless his wife is also a carrier. So this whole pattern does not fit into autosomal recessive. Carriers marrying carriers is very, very difficult, or everybody marrying a carrier or everybody being a carrier doesn't make sense. An autosomal dominant disease means essentially this will fit partially, but suddenly you find these children who are born to apparently normal parents. So in autosomal dominant, every generation will have somebody affected or the other. So here you have that the parents are normal, but the child is affected. So it is not fitting into autosomal dominant pattern. So what is it fitting into? So this whole chart is fitting to what is called a sporadic inheritance pattern, where you have normal parents, abnormal child, you have abnormal parents with normal children, and everything is very, very mixed up and blurred. That is called a sporadic inheritance. Sporadic inheritance is very well known with Kearns-Sayre syndrome, where you have something called heteroplasmy. Heteroplasmy means there's a mix of mutated and non-mutated genes. The amount of the mix decides the presentation of the clinical signs. You have more mutated genes, you have more clinical symptoms. You have less mutated genes, you have less clinical symptoms. This inheritance pattern, where you find the great-grandmother affected, she has 2 children who are affected and about 3 other children who are all boys unaffected. The first son, who is unaffected, seems to have another boy who is affected like his grandmother. So this kind of sporadic inheritance pattern is commonly seen in Kearns-Sayre syndrome. This is heteroplasmy. So this question has got 2 sections, one in which you learn about sporadic inheritance and the clinical picture fitting into what is called Kearns-Sayre syndrome. Also remember the X-linked recessive disorders, which are the autosomal recessive disorders, which are the autosomal dominant disorders, so that even if you didn't know the clinical picture, just by looking at this chart, you should be able to kind of come to which is the diagnosis. Okay, so let's go to the next question. Now this is a question vaccinology. Now you are given 4 VVMs, okay, called the vaccine vial monitors. 4 VVMs have been given. Which of these are suitable for vaccine administration? Now you have one where the inner sphere is darker. You have the inner square which is darker than the surrounding. You have one which is the same color, and you have 2 where it is lighter than the surrounding circle. Now, as per the National Immunization Guidelines, the vials which are considered to be potent or not exposed to heat are vials where the inner square is lighter than the outer circle. So the vials 1 and 2 are lighter than the outer circle. So these are potent and they have not been exposed to heat, which is the purpose of the vaccine vial monitor. One where the vial, the square is at the same color or darker, these are vials which cannot be used for the vaccination because they have the vaccine inside them is no longer potent. It has been exposed to heat and it's a heat labile vaccine. Remember, this kind of vaccine vial monitors are not only used for polio, they are used for many heat labile vaccines as well. Okay. Now, next question. This question was kind of between anatomy and us as. Then, which are the number of vessels in the normal umbilical cord? Is it 2? Is it 3? Is it 4? Is it 5? Now, the normal umbilical cord cross section looks like this. Okay, this is the cross section of the vessels of the umbilical cord. You have a large umbilical vein and you have 2 umbilical arteries. Now, the 2 umbilical arteries and the 1 umbilical vein is what you see in the normal cross section of the umbilical cord. So the answer is B. There are 3 vessels in the normal umbilical cord. Now, for the point of discussion, what happens to the other umbilical vein? Now, at the time of conception and till almost the 7th week, okay, till the 7th week, 4th to 7th week of gestation, there are 2 umbilical veins plus 2 umbilical arteries, okay. So, till the 4th to 7th week, actually there are 4 vessels. So, remember this question, you must remember very carefully. If the question says, what are the number of vessels in normal umbilical cord within the 7th week of pregnancy? The answer is 4. If it's after the 7th week of pregnancy, it is 3, or at term gestation or at delivery, it is 3. Why? Because the right umbilical vein, what happens to it? It regresses and forms what is called ligamentum teres, the posterior aspect of the falciform ligament. So that happens in the 7th week of pregnancy itself. So yes, at the time of starting there were 4 vessels, 2 veins and 2 arteries. But the right umbilical vein regresses and by 7th week of pregnancy it just forms a small stretch of ligament which is called ligamentum teres, and this is formed at the posterior aspect of the falciform segment. Persistence of the right umbilical vein is also not good. It is accompanied by a certain amount of congenital malformations and abnormalities. Similarly, like a single umbilical artery. If you have single umbilical artery also, you have cardiac, renal, so many other dysmorphic features, all this present when you have single umbilical artery. So I hope all that information was very useful and will come to use as the time goes by. So with that, we have come to the end of discussion of NEET PG 25. Wishing you all the very best. Happy learning. Thank you.